Hello, my name's Catherine Downs and I'm an anaesthetist, a cardiothoracic and obstetric anaesthetist from Sydney. I've been asked to talk today about viscoelastic haemostatic assays under the emergency transfusion component of the lifeblood transfusion course. So this talk follows the emergency transfusion critical bleeding lecture that Alyssa Milford presented a couple of weeks ago. So hopefully you've had a look at that talk already with the background on critical bleeding. Today I'm going to follow from that talk and I'd like to give you these learning objectives. Firstly, to define viscoelastic haemostatic assays, a bit about their history and their evolution. Then I'm going to talk about the current technologies we commonly use in Australia, their reagents and how the curves look, and some evidence behind it just briefly. And how do we translate that evidence into local practice? So I've created an algorithm that marries the different technologies for ease of comprehension, and we're going to walk through that algorithm and then do some case examples. And finally, what's holding it up? So when I was a registrar back in the 1990s, one problem was that we couldn't get enough blood fast enough for obstetric, traumatic, surgical hemorrhage. It was really a difficult time, and then the system of packs was introduced, and it really did save lives. We called it the Massive Transfusion Protocol, and things got better. But since then, more technology has become available. And so how do we define viscoelastic haemostatic assays? Well, I quite like this definition from a paper in 2022. It says viscoelastic haemostatic assays are whole blood point-of-care tests that have become an essential method for assaying hemostatic competence in liver, cardiac, and more recently trauma and hemorrhagic shock. The important points being that they are whole blood and that they are point of care. So let's dive into that a little bit. Standard lab tests, as you know, give a biochemical diagnosis, but there's no assurance that it correlates with a clinical picture. The lab tests were not designed to predict coagulopathy or not. They're also not done at the point of care. There's a significant delay getting lab tests back, and when they're done at the point of care, you can get a result in 10 minutes or so. The key questions when you are at the point of care in a critical bleeding scenario as the boss are, why is my patient bleeding? And is there coagulopathy? We want to solve these problems and get a good outcome for our patients, and we need an answer quickly. So this is the mindset. The Massive Transfusion Protocol, it was good, it had its time, it still definitely has a place, particularly around the world. However, here in Sydney, massive transfusion protocols with packs treat all patients, well, everywhere they treat all patients equally. And what we don't want to do is treat all patients equally. Do all critically bleeding patients have the same requirement? No, of course not. We know that sometimes people have a trauma coagulopathy, or people might have an amniotic fluid embolus and have a coagulopathy from the outset of their bleeding. Similarly, with aortic dissection coming off bypass, people can have a coagulopathy very early. So not all patients are the same, and not all patients have the same requirements. But the PAC system treats all patients equally. Now, these viscoelastic tests have been around since the 1950s, but they required pipetting and significant skills in their early days. And around 2015, the cartridge-based technology, so nearly 10 years ago, became available in this country. So we now have a way of making goal-directed, individualised, rapid decisions at the point of care. So these tests must be used with a protocol. And the 2023 National Blood Authority guidelines that I'll look at in a minute would like us all moving forward to call that the Massive Hemorrhage Protocol. And I'll come back to that. But first, what do these look like? What does a viscoelastic machine look like? So it looks a bit scary. Take a deep breath. It looks a bit like a desktop computer, or a bit smaller. It's a machine with a screen. And on the top left, you'll see Rotem Sigma. It is a pin and cup technology. Pin and cup's been around since the 1950s. Essentially, there's a pin in a cup full of blood. It spins. Initially, it's very liquid, and then it measures the resistance as a clot forms, the resistance to the movement of that pin in the cup, and it shows that as a resistance or a temogram. Now, you'll see the little a cartridge there with 5 cups in it. 4 of them are a test and 1 is a control on the left-hand side. We'll use Heptam cartridges for all our cases. And the TEG 6S is a similar technology, except that it uses a cartridge that has resonating plates. So it's a much, much newer technology than the pin and cup, but the same idea, that it's measuring the resistance as the clot forms. And it's best to use these at the point of care. And then the results can be at the critical bleeding patient or the critical care team quicker. So here I've got a picture of our very first Rotem workstation. And on the bottom left, there's a Rotem machine, and on the bottom right, there's the blood fridge. And then there's the two original Rotem algorithms on the wall with a few emojis and thinking, should we always use a label? What's the hemoglobin? Are we using the correct algorithm? Tell the blood bank you're using the protocol, and a few reminders there to engage the staff and to make it easier to use. And we always use it with one of these algorithms because viscoelastic hemostatic testing is a science. It's not an art. So we need to keep it simple. And the good news is that you already speak part of this language. So managing critical bleed is hard enough without needing to learn to speak a new language. Each cartridge runs 4 tests. So think about what coagulation tests you already know. A few come to mind, don't they? And here they are, and I'm going to try and make it as easy as I can for you, simplifying it a lot. The extrinsic pathway, we know, is assessed by a prothrombin time or an INR, and the analogous assay in a Rotem is the XTEM, extrinsic pathway temogram. The analogous assay in TEG technology is called a CRT. It's similar. It's not the same. It in fact also has some kaolin, and it does not remove the heparin, but it is the most similar, and it does have tissue factor. It looks at the extrinsic pathway. The second one on this list is the APTT. We all know what that is. It assesses the intrinsic pathway. So in viscoelastic language, that could be an INTEM, a temogram of the intrinsic pathway, or it could be a CK, a kaolin test in TEG. Thirdly, fibrinogen. A Klaus fibrinogen is familiar, hopefully, to all. We want to look at the fibrinogen contribution. In Rotem language, we will call that a FibTem. And in TEG language, we will call that a functional fibrinogen, CFF. Very similar. And essentially, as you can see from the arrow on the right, the fibrinogen contribution is assessed by looking at the extrinsic or XTEM and removing the platelets with some reagents. And I'll come to that in detail in a moment. Finally, the HepTem. Imagine if you could have an APTT without heparin so that you could see whether it was prolonged because of heparin or not. This is what it's doing. You're giving a HepTem or a CK with heparinase, which is a test that shows the heparin contribution to the problem. Very useful in patients on heparin, particularly on the heart-lung machine. So now that we've thought about the 4 different tests, now let's have a look at the shape of a temogram and what it looks like. So this is a temogram, and firstly I'll start with the Rotem parameters. There's a clotting time. On the very left-hand side, you can see at the bottom the time it takes for the clot to begin or some resistance to occur between the two things, the pin and the cup. Then as the temogram starts to form, it gets thicker and thicker and thicker. So there is a how fast does it start and how strong does it get. And how strong does it get? It's got to do with platelets and fibrinogen. And how long does that last? Does it stay strong? That's got to do with fibrinolysis. And so we want that thick trace to stay thick the whole time. And of course, there may be a level of lysis depending on the clinical situation. So how fast, how strong, and how long. It's giving you 3 different things, or many different things, not just a number like an APTT or an INR. And this slightly more complicated slide includes both Rotem and TEG language. So we've just looked at the top half of this trace, clotting time, etc. Looking at the TEG language, the clotting time is called an R time, reaction time. And the strength of the clot could also be measured at 5 or 10 minutes, or it could be at the maximum clot firmness. And then it also looks at the lysis and that lysis index, which is how much it disappears over time, how stable or how unstable is the clot over time. So this is what the traces look like. It's called a temogram. So just coming back to this slide I showed you before, I'd now like you to look at the screens. So on the left-hand side is a Rotem Sigma screen. It's got a white background. It's got 4 different temograms: FibTem, XTem, HepTem, InTem, and they all have different parameters. On the right hand side, if you look at the screen of the TEG 6S, it has a black background. It also has 4 parameters, but it's just the outside line that's drawn, and they're drawn over the top of each other. So slightly different, but overall similar. This is a slightly scary slide, so I'd like you to focus on this slide a quarter at a time. So let's start at the top right, the XTem. Now, I already mentioned that the XTem looks at the extrinsic pathway. So looking at the whole top right of this image, forgetting about the rest of it, there's 2 different pictures. One of them is the Rotem XTem. It's got tissue factor and calcium chloride, but it's also got some polygreen to remove heparin. So it's looking at the extrinsic pathway. The analogous test, the closest test in the TEG, is called a CRT. So it also has calcium chloride and tissue factor. It is looking at the extrinsic pathway, but it also has some kaolin and it doesn't have any heparinase. So we just have to keep that in mind. But they both look at the extrinsic pathway. So now moving to the left, we're going to go anti-clockwise, looking at the top left-hand side of this image. In the middle of the screen, we're looking at the FibTem. So this is analogous to a Klaus fibrinogen. In the Rotem, the white one in the middle, we will see it's essentially the XTem that we were just talking about, but you've added 2 different reagents to kill the platelets. So therefore, it's quite pure in that all the platelets are gone, and it's just looking at the fibrinogen contribution to the clot. Then in the very top left, there's a functional fibrinogen, CFF, with the black background. That is the analogous test in a TEG. It has a single reagent, abciximab, removing the platelets. So there's a little bit of platelet noise with 1 reagent, but essentially it's looking largely at the functional fibrinogen. So the top left side of this screen is FibTem and CFF fibrinogen contribution. And think of that like a Klaus fibrinogen. And then in the bottom left, we're looking at the intrinsic pathway now. So the InTem. In the Rotem in the middle, it's calcium chloride with ellagic acid, and at the bottom left, it's activated by kaolin. So this is an intrinsic pathway activation. Very, very similar. And the bottom right, also very similar, very easy to understand InTem and HepTem in both TEG and Rotem, because they are both activated intrinsic pathways, and the HepTem and the CKH is for heparinase, are both tests that look at the intrinsic pathway, and the one with the heparinase, HepTem has heparinase, and CKH, H is for heparinase. So they show you what it would look like if the patient was not on heparin. So it gives you a window into what would happen if you gave Protamine. So the TEG cartridge is called a global hemostasis cartridge, and the Rotem assay is called a HepTem cartridge, and these are the most commonly used cartridges. I'm not going to get into details of different types of cartridges. There are other options for advanced testing. This is what we need to know for your normal patient to say, is there coagulopathy or not at the bedside, and how best can I treat that? Now, the best science in the world means absolutely nothing if you can't get the humans to engage. So let's have a look at a little bit of global evidence and the local way to implement that. You need a local team of champions to get this to work. You can't just buy a machine and put it in the corner and expect it to do it for you. You need a team, you need a plan, and you need to work within your campus-wide transfusion committee. So this is a real interdisciplinary task where the teams of critical care physicians and the hematologists need to work together, or it can never work. Just as an example of some of the data out there, I'm going to show just 3 slides on data. This is the European guideline, came out in the European Journal of Anesthesiology last year. A few statements I've pulled from that. Viscoelastic Haemostatic Assays can identify obstetric coagulopathy, including hypofibrinogenemia and a reduced platelet level. They guide hemostatic treatment, and it reduces the need for blood products. In severe postpartum hemorrhage, they suggest using a protocol. And then it goes on to talk about using this category 1C for invasive procedures on cirrhotic patients. Also mentions prothrombin complex, using it before giving PCC, mentions cardiac surgery, which I will present next. This is a slide. I have permission to present this from their lead author, and it's going to be presented at a meeting as a poster shortly. They've done a meta-analysis of 10 different RCTs looking at viscoelastic hemostatic assays. These are all in cardiac and vascular surgery. And 7 of these are Rotem at the bottom right, 3 of them are TEG at the right middle, and the top section shows all the forest plots comparing the two. The forest plots of VET RCTs, VET viscoelastic testing. And so just overall, as a meta-analysis, you can see there is definitely merit, and this one looks at trauma. I also have permission to present this, showing that there is merit in using this in terms of mortality for severe trauma. It's easy to deep dive into all of that data, and we really don't have time for it here, I'm sorry. So, at the Prince of Wales Royal Hospital for Women Sydney Children's, where I work, there's also a private hospital, so it's a 4-hospital campus, and we were the first centre in Australia to purchase the new first-generation Sigma machine in 2015. So taking the global protocols and talking about how we worked on that at our little centre. And each little centre needs to work out their own way to do this and to make it work with what they have. So we purchased the pin and cup technology because that was at the advice of our haematologists, because the pin and cup was a decades-old technology. And back in 2015, the plate system was new. Of course, now there's quite a lot of evidence around all of that. But we implemented it first into cardiac surgery. It's now used across the campus. We've always worked within the campus-wide transfusion committee, and we wrote this up in Australasian Anaesthesia 2017. So you can get a copy of this if you Google it, or if you email the Blue Book people at the College of Anaesthetists. But our article called Viscoelastic Haemostatic Assay Guided Blood Product Transfusion and How to Introduce It into Your Hospital is as relevant today as it is to any centre that has not yet implemented this technology. It goes through all the pitfalls and how we got people engaged, and we really made it interdisciplinary. So after a couple of years of getting it to work and moving it across the campus, we then had to embed it into our what was a massive transfusion protocol. And at that time, our haematologist decided to call it the critical bleeding protocol. So we have this, which is called the critical bleeding protocol. It was brought in 2018 as a collaborative effort with the Rotem working party, working underneath or within the transfusion committee. And so we essentially made a plan where when you call a bleeding protocol, you are issued with 4 units of PAC cells. All you have to do is say, I'm calling a bleeding protocol, and then you will either get the PAC system or the Rotem guided system. And it works like this, where the Rotem guided, after you've got your 4 units of PAC cells, you will then refer to the algorithm. And these are all available on the intranet and on a QR code we have on the machines. And they will give you the yellow products that you need. And hopefully you've watched the video as pre-reading of this talk, which talks about the yellow and red products and how this works. If you choose non-Rotem guided, and occasionally this still happens on our campus, if it's one of those bleeds on the ward and they initially just call for a PAC, and then when the team arrive, and the PAC then is the PACs that you're aware of. I'm not teaching about massive transfusion PACs here, but that's how they work on our campus, and these are used occasionally in the first round until the team from ICU or anaesthetics arrives. And of course, we're doing more and more education across the campus as time goes by. It's important then to audit what you're doing, and this is one example of that. This is a poster that we presented at the college meeting this year, and it essentially goes over our algorithms, some of our statistics and how it's gone, and the QR code where we can look at the algorithms, and it's also got an audit in there that we're doing. So just to point out that when you implement it locally, you need to be auditing it and looking at what you're doing. And this is also available on my website there, downs.com.au, if you want to read this poster. I'm not reading it now. So this is the summary of our Randwick campus critical bleeding protocol for adults. It's the same as something at your hospital, I'm sure, and it says activate the protocol. These are the blood tubes to take. This is the phone number. Choose Rotem or non-Rotem guided. It goes through what I've just told you about. It talks about basic parameters with a fibrinogen greater than 2 as your goal. It talks about what to monitor and how often, and a little bit about Beriplex and when to consult a haematologist, such as if there's NOACs involved. And also, of course, to cancel the protocol when you're finished. So the big thing that's happened in the last year is that it was 2011 last time the National Blood Authority created a guideline like this. So the update was much waited for, much anticipated, and was published this year in February 2024 in the Medical Journal of Australia, the NBA guideline for patient blood management and guideline for critical bleeding for Australia. And so this document goes through all kinds of things, and I implore you to read it. But the main takeaway points that I will point out here are that it talks about evidence suggesting that we should use it. It might reduce mortality in cardiothoracics. Of course, it's looking back at data. It recommends to always use a protocol. I think I've said that enough times. It talks about the fibrinogen level targeting more than 2. And you can see its structure there with the do we have a VHA, yes or no, in the middle of it. And the more detailed slide that the NBA has and would like us to use for education is this slide. So it's got on the right hand side the protocol I just showed you, and on the left hand side a little bit more about what to do when a patient's bleeding, how to resuscitate them, and things that you've already been over. So interestingly, comparing the two, the left hand side is our Randwick protocol from Sydney in 2018 that we developed, and the right hand side is the 2023 National Blood Authority protocol, and you can see the similarities. And so essentially, it's what I've just gone over, except that as of this year, all new protocols, they would like us to call them massive hemorrhage protocols. The point being that we're now managing a massive hemorrhage with targeted goal-directed therapy. We're no longer expecting to do a massive transfusion. So it's a nuance, but it's important. So with our next rendition, we'll probably then call it the massive hemorrhage or major hemorrhage protocol. So how do you implement these locally? There are so many stakeholders. It's really all about education. And so for this session, I have created a combined algorithm, and I have combined Rotem and TEG. I've spoken to a number of people from different hospitals, my colleagues, and we have created an algorithm that shares the two technologies so that you can learn them and understand them together. Even though they work a little bit differently, it's better to understand them together and understand the differences, I believe. So let's talk about Rotem and TEG and have a look at a combined algorithm. Here's the merged algorithm. It starts at the very top with physiological targets. And is there clinically significant bleeding? Please do not do a viscoelastic test for a patient who does not have clinically significant bleeding. That is not evidence-based medicine. And we say that at every meeting. You don't do a baseline test on this. Baseline tests are lab tests that you already know and you already do. We do this in a critical bleeding scenario, and we use evidence-based medicine, and we will be able to use it to get on top of our critical bleed in most cases. Of course, not all cases, but most cases. A couple of runs through this algorithm and you will have a solution, and if you don't, then you escalate it to hematology. So starting off, is there clinically significant bleeding? Yes. Think about tranexamic acid, give it if you think you need to, and then take your Rotem or TEG. Then you'll have a result 10 or 15 minutes later at your point of care. Look at the temogram. First of all, think about fibrinolysis. Hopefully it's not present, but if the graph is tapering, you'll be giving tranexamic acid. And then you go straight on to check for low fibrinogen. Is the amplitude at 5 minutes meeting the threshold? Give fibrinogen if not, and then up around the loop, back to the top on the green line, retest. Recheck your physiological targets, come back down the algorithm, make sure you're not now getting any fibrinolysis and that your fibrinogen is now normal, which it should be, and I'll show you the next slide how we actually can prescribe the dose depending on how low that fibrinogen calculation is. I've just made this relatively simple to show you can go around the loops, that go down the loop, the fibrinolysis is not present on the left, the fibrinogen is good on the left. Platelets, now we're thinking about platelets. Do we meet those criteria? Perhaps there's a poor platelet contribution. There are other tests such as multiplate and platelet mapping, and then we can give some platelets if needed. Then you check it again, retesting, going up and around the algorithm, and almost always it will now be normal and the bleeding will be settled. And occasionally the XTEM clotting time or one of the R times will be prolonged and plasma will be indicated. We also, sometimes if a patient is overloaded, and we really suspect that the extrinsic factors are a problem, then we might use Beriplex, which is a 4-factor PCC, remembering that there's no real TEG test looking for the extrinsic pathway. So you might need to look at other tests or empirically decide whether or not to give the Beriplex or go with FFP. So this is the same image, but with a bit more detail on the right-hand side, not to learn, just to see that when you come across with a low fibrinogen, there is of course a calculation that can be usually on the next page of the handbook or next to it on the wall. If your number on your TEG or FibTem is a certain number, it prescribes how much apheresis cryo or whole blood cryo or how much fibrinogen that you should give, to then expect that when you go up and around the algorithm, it will be corrected when you retest and you can look at the next step. Similarly, there's a section on platelets looking at whether to give 1 or 2 pools of platelets depending on how dire the result is, and so it goes on. So we can get right into the nuances of what to give at the bedside from that result. So walking through this algorithm step by step. First of all, physiological targets. Is there significant bleeding? Giving the tranexamic acid and taking the test. Then looking at the temogram. Is it at any time, now or later, tapering away? In which case, if you haven't already given it or if you've lost a blood volume, tranexamic acid. That's one thing that's changed a lot in the last 10 years or so, is the more proactive use of tranexamic acid. So we prioritise the management of hyperfibrinolysis. It is absolutely futile to give fibrinogen if it's going to be rapidly consumed, and I think we all know that. So now I'm going to show you some temograms for fibrinolysis. Starting with one that's normal. At the top is the XTEM, at the bottom is the FibTem, and of course you know that the XTEM is fibrinogen with platelets, and this is a Rotem trace, so it excludes the intrinsic pathway and heparin. And the FibTem is an XTEM without the platelets. It's double inhibited. What would it look like if there was fibrinolysis? Well, it tapers away. So take a little mental image of that. Thinking of a sausage on the barbie, it's a chipolata, a little short sausage that comes and then disappears. And one of the speakers, James Winnells from Queensland, does a great talk about explaining it like that. So if you think about it coming and going, it tapers away, and that is a fibrinolysis trace. Once you're happy that you've managed that, you just proceed with the algorithm and look at the fibrinogen, whether or not it meets the threshold that's approximately equivalent to a class fibrinogen of 2. So if your FibTem at 5 minutes is less than 12 millimeters, or your functional fibrinogen on your TEG is less than 15, these are approximately equivalent. That includes if it's 0 at 5 minutes with a flat line, these people need fibrinogen. And then I'll show you again bigger, of course, the algorithm for that in a moment. As well, if your fibrinogen is then normal, you will look at your platelets, and you might do some further platelet testing, but these show criteria that make you think platelets. In the presence of a normal fibrinogen, then you can start looking at platelets. So this is the detailed algorithm, not to scare you, but just to show you generally that if you look at the FibTem or the functional fibrinogen level and you meet certain thresholds, you can then give cryo or fibrinogen concentrate at a dose, and there's so much data on this in the literature and so many different algorithms around the country, and I've looked at most of them, put them all together. Essentially, you could give a nuanced dose, or you could just give a mid-range dose and check it again. Some centres try to keep it simple and do that. And you can see there's a fairly good correlation here between the FibTem, the Rotem fibrinogen with double inhibition out of your XTEM, giving you just the fibrinogen amount correlating with a class fibrinogen. So therefore, in summary of that, the general principle is that it recognises the key role of fibrinogen in coagulation, and fibrinogen falls first to critical levels during bleeding. So this is why we use goal-directed therapy. We know that fibrinogen falls first. A low fibrinogen in PPH is an independent predictor of your likelihood to have a severe PPH, and there's papers on that. And so we give it either as apheresis cryo or as concentrate. These are the numbers, and we use the dosage schedule. VHA protocols usually have a defined series, and we start with clot strength. This is because we know that clot strength is the most important thing. So even though sometimes you might be presented with how fast does it start clotting time first, it's the clot strength that you are looking at first. And that is really important, because commonly once the patient physiology of the fibrinogen is fixed, everything else gets better. We don't need to be giving other products such as these ones. So once the fibrinogen is met these guidelines and been corrected, then you can go on and have a look at your platelets, and if these criteria are met, there may be a poor platelet contribution. Of course, if you have a low platelet count, you should be treating that right at the top of the algorithm. You can go on and do some more nuanced testing of platelets if you have that facility. And this is once again a normal Rotem, the XTEM at the top, looking at the extrinsic pathway, fibrinogen and platelets, the bottom one with the platelets double inhibited. And what does it look like if you have a problem with low fibrin concentration? Can you see how they're both thinner? Because fibrinogens are part of both. So if you have a thinner temogram in both of them, you're thinking about fibrinogen. Going on to factors. So if you then get to a stage where you've corrected your fibrinogen, you've corrected your platelets, and the patient continues to bleed, then we're looking at the clotting time. So a normal FibTem and CFF is the clotting time prolonged. So that could be due to medications, or it could be due to low clotting factors. We would replace it with FFP, and sometimes with Beriplex, as I mentioned before, if the extrinsic pathway is suspected. But most commonly the clotting time is prolonged due to low fibrinogen, and when you retest it, in fact, the clotting times are normal. And commonly, in fact, usually we don't need to give extended life plasma or any kind of PCC, such as Beriplex, if you can wait and check all of these things. If you've done all of that and you're still bleeding, clearly there's a surgical or obstetric problem, so-called proline deficiency, or a problem with uterine tone, for example. And of course, long before that, you will have got review from these people. You can push for stronger clot with all of these factors if you want to. Recheck basic things. Think about factor 13 and von Willebrand's disease, and go back around the algorithm. But make sure you're definitely getting your other teams involved well and truly by now. Then, I've got another algorithm that I'm going to show you that's a TEG algorithm from Melbourne. And this one talks about something I mentioned earlier. It's a really nice way of thinking about it, actually. How fast until it starts, how strong does it get, and how stable is it? Now, I mentioned that at the beginning when I showed you those temograms. How fast, you might address that first if you know the patient's heparinized, for example. And I'll talk about the cardiac algorithm in a minute. So if it takes a long time for the blood to start clotting and they've been on heparin, of course, you might then be giving protamine. But mostly, nearly always, we start by looking how strong the clot is. Unless they're heparinized, how strong is the clot? That's where the main information is. Is it strong? Is the functional fibrinogen normal? If the functional fibrinogen is not normal, fix it, and then look at how strong it is again. And if the functional fibrinogen is normal, then you're thinking about platelets. So it's the same as the other algorithm, looking at how strong, looking at how stable, and then looking at how fast it formed when you recheck it. So just to summarize, why VHA guided? It's a quicker result. It gives you a global assessment, not just a number, measuring the first stage. It's goal directed. It's actually giving you something to do in answer to the result, not just giving you a result. Studies have shown there's less blood products overall administered, and also less morbidity, and some of those forest plots suggesting less mortality. It's at point of care. It's got a fantastic negative predictive value. If the viscoelastic test is normal, you've almost always got a surgical or an obstetric problem. In order to get this translated easily across all staff, including our nursing staff and other staff that may be bringing the test or the printout to you if it's situated between the two theatres, we established a decision support tool locally at Randwick campus. And so it looks like this, and I actually sent some of these, so hopefully some of you have printed these out so that you can use them when you do the examples at the end. And so these decision support tools are available at all the machines, and they go through the key 6 numbers that come out of the machine for the Rotem machine, and you can then circle if you're in the red zone. Now the orange zone I've prescribed is a wait and retest kind of zone. So we're looking at the red zone, completing a management plan and putting it on the chart. It gives good accountability, and just to make sure that we realise that the orange is wait and retest, but the orange means make sure you've got those platelets on site. Think about, especially if you're somewhere that doesn't have everything on hand, you're in the orange zone, you might be in the red zone at your next test. So we don't normally treat the orange zone, we just have that as something to be aware that we are nearby. And green is good. So therefore we always use a sticker. It absolutely reduces individual variation in clinical practice, and it improves accountability and communication. And just to show you one of our early stickers, it looks a bit different, just an example of what it looks like stuck in the notes and being handed over. Yellow, yellow, green, green, normal Rotem. So now I'd like to go through some case examples. First of all, I'm going to remind you of this slightly scary looking slide with the XTEM and its CRT and the TEG, with the FibTEM and its CFF or functional fibrinogen, and it's got an INTEM looking at activation of the intrinsic pathway, and a HepTEM, which is intrinsic pathway with heparin removed. So just with those 4 things in your mind, I'm now going to have a sip of water and take you through some case examples. Got that? It's a very scary slide. Next, obstetrics. The most important thing, and I've already said it, you do not treat the patient unless there is clinically significant bleeding. Case number 1. Hopefully you've all printed out your algorithm and your stickers, or you've got the algorithm up on a screen somewhere so you can look at it, and a sticker that you could fill in. This is my first example. This is the printout the nurse would bring you. This one is from a Rotem machine, and I'm going to give examples from both machines. So the FibTEM A5 is 14, and you can read there your XTEM clotting time and A5. If you fill them in on your sticker, perhaps pause now if you want to, compare it to your algorithm, or while you're filling it in, I'm just going to tell you something about this. So this next slide shows the use of Rotem. It's a poster we presented a couple of years ago at one of the national meetings, where we looked at first Rotems done across the campus. We looked at something like 400 patients, and the most important thing I thought from this was that in obstetrics and gynecology, when you do a Rotem for a bleeding patient, it's only abnormal 1/3 of the time. 2/3 of the time there's an obstetric problem. 1/3 of the time there's already a coagulopathy. And the bubble on the right hand side shows that in this particular series, all cases where there was obstetric bleeding and an abnormal Rotem, fibrinogen was a problem. So thinking about obstetric bleeder number 1, we fill in our sticker. We're looking at the yellow and orange zone here, and we're using the negative predictive value here to say that this is a normal Rotem, and therefore it's got a good negative predictive value to get the obstetricians involved very early. So now I'd like to look at obstetric bleeder 2. This is a very common pattern, and the one that we most commonly see and that I just described when the test is abnormal in obstetrics. And so here we are looking at a FibTEM A5 of 11, and then you've got the XTEM results there. If you'd like to pause and fill them in on a label and compare that to your algorithm and have a think about what treatment plan might be required for this patient. Comparing to your algorithm, you can see there's something in the red zone now. And the key role of fibrinogen in coagulation is that it needs to be given early. It's the first to fall. And if you read off the algorithm, this patient required 2 units of cryo and an obstetric intervention, probably not too bad a coagulopathy. For the next one, obstetric bleeder number 3A. So this is an antepartum hemorrhage. They had an urgent GA Caesar. You can see here, and the main learning point, on the right hand side, when the fib-tem looks absolutely terrible, it's not a broken machine. It is probably a very early coagulopathy, such as an amniotic fluid embolus or an antepartum hemorrhage, as in this case. So looking at the numbers here, and if you fill them in on your sticker, you will see that they are very abnormal. And when you see this flat line, you need to activate your local protocol and get 4 units of red cells quickly, and you are also likely to need lots of fibrinogen and maybe platelets. This should be an image that makes you feel like this. So back to this patient, the learning point is that this is a seriously abnormal rotem and fast action is needed. So circling the red results here onto your sticker, and let's make a management plan. You might want to pause it if you want to think about that. But essentially, this patient will have had some tranexamic acid. These are their results. You need to action the fib-tem there. There's a low fibrinogen. Comparing to your algorithm, this patient would receive tranexamic acid and 12 units of apheresis cryoprecipitate and then a retest. In this example though, something unusual happened in that the enthusiastic team ran another test before they'd given all 12 units. And this creates an interesting teaching example where you can see here, after 5 units of cryo were given, that the A10 in the fib-tem has come up to 7 millimeters, or 6 millimeters rather. The A5 has come up to 6 millimeters. It's not fully corrected, but still you need to finish giving your dose. You need to be giving 8 more cryos, and then the rotem was normal and the bleeding settled. The learning point here is that please follow the algorithm. That was a wasted test, and this patient required 4 units of red cells and 12 apheresis cryo and avoided a massive transfusion, didn't have FFP or platelets. Now let's talk about obstetric bleeder number 4. This is a placenta previa and an elective Caesar, spinal, changed to a GA. A massive bleed when they were closing. So at first it was okay actually. It was when they were closing that the bleeding was really noticed. So this is a very scary looking trace. I hope you have the look of that emoji with a very scared face looking at the fib-tem where there's no number in the box and it's flat, it's not broken, it's 0. So if you would like to pause and fill in these numbers, you'll notice the shape of this trace. You'll also notice the numbers are abnormal. So let's fill them in and have a think about this placenta previa at the bedside. What are we going to get ready? Filling in the label, these are our numbers, and looking on the left, the treatment plan will be tranexamic acid, 12 cryo, and you may want to give some platelets, depending on the amount of bleeding, or you may want to retest and see if you needed those platelets. I think on this occasion they were all given because it was such a lot of blood so quickly, and it was, I think, missed for a little while. It was occult under the drapes, so they gave all of those things quite quickly and the repeat rotem was normal and the bleeding settled. So next I've got a couple of case examples for general surgery. And so the first one is an anaphylaxis. This is an anaphylaxis under GA, and now the patient is very oozy. So here we can see a very unusual looking fib-tem and X-tem. You'll notice things about that trace now because you're starting to recognize patterns. I'd like you to notice this number that says the lysis is 100%. So filling in your label, have a think about what are you going to do. Look at these numbers, X-tem clotting time, X-tem at 5 minutes, fib-tem at 5 minutes. And what about the ML? So now that you've filled in your label, the fib-tem and the X-tem ML are 100%, and the X-tem A5 is only 26 millimeters. Tranexamic acid is required. There's a severe fibrinogen deficiency. 10 units of apheresis cryo is indicated using our algorithm. Because we're in the danger zone, platelets should be ready and platelets may be given. I think it'd be better to have them ready depending on the direness of the situation. That's not a word. On retest, after this was given, In fact, after tranexamic acid and 10 units of cryo, the test was then normal. And so the learning point here is the tranexamic acid and the fibrinogen were done properly, the test was repeated, and the platelets were not required, because on the retest, those numbers were normal, and the patient stopped bleeding, and plasma should only be given if on the retest there's a long extem clotting time. So that's a few examples using the Rotem back-to-back to get used to those patterns. Now I'm going to give you a few examples using the TEG. And so just a little reminder that the clotting time, which is, the clotting time is what it's called on a Rotem, it's called an R time on the TEG, the time for some kind of clot to start forming. And then the amplitude at 5 minutes for a Rotem is equivalent, well, they don't use 5 minutes at TEG, they often use a 10-minute A10 or a maximum value, but the A10 is usually looked at in a TEG. And then there's the lysis, well, that's the same, although it is measured slightly differently. I'll mention that in a minute. But this is just one general surgery example where this is a patient who is having liver surgery, and we're looking at the clot and the numbers. Now, I'm very grateful to my colleague in Melbourne from Austin, Lachlan Miles, for going through and loaning me these TEG examples. So this is an example using a TEG machine. It's got a black background, it's got the outlines. We are looking at the same algorithm though. We're looking at how strong is the clot. At 10 minutes, we've got 71 for the CRT and 43 for the fibrinogen. They are both very large numbers. And looking at this and then looking at the algorithm that we've been looking at, just on the right hand side there, you can see that all of those numbers are hypercoagulable. There's no chemical cause for bleeding, and if anything, the patient is at risk of thrombosis. So this is a way of going through this algorithm. We are not going to give tranexamic acid, we are not going to give fibrinogen, and we are not going to give platelets or plasma. None of those things are indicated. But, in the old times, before we had this, you might give some of those factors waiting for a result. So the next patient is also a TEG example. It's a pelvic exenteration, and the surgeon was unable to close at the end of the case because of the ooze. There's 1.5 liters of blood loss and 4 liters of crystalloids being given. So once again, we're looking at these key equivalent numbers in the TEG. And so there's no lysis there. These are our numbers for the clot strength at 10 minutes. And if you remember the numbers from the algorithm, they are a little low. And there's our R time 9.5. So let's look at the algorithm now and compare them. So we have got an R time. Well, let's look at the clot strength first, sorry, because that's what we're supposed to do. There's no lysis. The clot strength at 10 minutes here is more than 15, it's less than 15. It's 6.5 in the TEG. So fibrinogen is required. And you can see what I do written there is a severe fibrinogen deficiency. So that would be replaced first, and then we would go up and around and look at the platelets, or sometimes if it's completely dire, give the platelets at the same time, depending on the clinical scenario. But we try to retest in between. In this case, the CRT at 10 minutes is 38, it's less than 44, and we haven't yet normalized the CFF. So once we give the dose of fibrinogen that's indicated, then we would check this again, and we will give platelets if indicated, if it remained less than 44. The CKH is prolonged, but it may well be improved by treating those other things. And so suggestion here, if you wanted to fix all of those things at the same time, you would give PCC cryo. However, normally we would treat it in steps, trying to avoid overloading the patient. So looking at cardiac surgery now, there's a different cardiac surgery algorithm. It's very similar, but it has a heparin step at the beginning. So I'd like to just show you that briefly and then talk through a few case examples in my final 10 minutes. So the cardiac algorithm looks like this. It has physiological parameters at the beginning and asks if there's clinically significant bleeding. It's exactly the same as what you're used to. If there's fibrinolysis, give tranexamic acid. Of course, most cardiac cases would already have had some, but maybe not all vascular cases. And we would give normal pharmacokinetic dose of 15 milligrams per kilogram, and then an infusion based on weight and EGFR as prescribed by the kinetics of the drug. That's what we run in our institution for tranexamic acid for equivalence. And that's already usually running. A TEG or a Rotem is then done. What you need to look at that's different with this algorithm to the pink one for obstetrics, this one is for cardiac, it looks at heparin effect first. And you are looking at the intem and heptem, or the CKR with and without heparinase. You're looking for if there's a difference in the intrinsic pathway with and without heparinase. I hope that makes sense. If there's a difference of more than 1 1/4, there's a heparin effect and protamine is indicated. And of course there's a schedule that would recommend the dose. If that's not present, sometimes you might see a prolongation of both of those things. Now, if both of those things are prolonged, commonly you see that when there's too much protamine or you've taken it immediately after the protamine. So normally we'd wait 10 minutes after protamine before taking a Rotem or a TEG, because you see the factor V inhibition that occurs as a result of peak protamine levels, and that appears as a prolonged intem and heptem clotting time, in which case you would wait and repeat the test. So we just need to be careful with our timing to take this test, that it's not when we're getting that little episode of factor V inhibition from our protamine levels being high. Once the heparin and protamine step's been looked at, we go straight on usually and look at fibrinogen and the fibrinogen levels, looping around, looking at platelets, maybe doing some multiplate or platelet mapping in cardiac, loop because they're often on platelet inhibitors, looping up and around to factors. It's really the same as what you already know. This is revision. Treat what's in the red zone, be ready if it's in the orange zone. So just to go over it in a little bit more detail, the tranexamic acid step, we use a protocol and it's based on weight, and that's for all pump cases. It's I think it's in the brochure that comes out of the box. It gives steady levels for all patients and respects renal impairment. And that's what it looks like, so that it's a bit closer and you can see it. The difference between with and without heparinase, more than 1 1/4. The effect of the protamine if it's in excess because it's taken too early. And this protamine excess effect is common because we're not really that patient. We commonly can't wait 10 minutes after protamine to do our test. We might see a little bit of this effect. So in terms of implementing global guidelines locally, this was a big part of something we did at our hospital after the European Association of Cardiothoracic Anaesthetists presented their guidelines in 2017. We then implemented a uniform schedule for protamine to reduce the amount that's given. It was previously given in quite high doses sometimes, and the amount to reverse should be 0.6 to 0.8 of the loading dose to go on to pump. And so we now have a written protocol where that's the amount that's given, and we have a lot less protamine overdose. So implementing global guidelines locally with an ACT, of course, it'll be prolonged if you've given not enough protamine, and also if you've given too much protamine. So an ACT doesn't solve the problem of if you've given too much protamine or not enough, which we used to always think we hadn't given enough and we'd give more. But now we have viscoelastic testing, so we can tell the difference, looking at with and without heparinase, as to whether there is indeed a heparin problem. So looking at heparin protamine management, this is a Rotem example. And so always starting with a normal trace. Now we've got an intem at the top and a heptem at the bottom, with and without heparinase. So now we're going to look at an example where there's heparin present. And so you can see the prolongation, and so it's how fast it's longer, how strong it's weaker. So that is the difference. And of course the heparin's been removed in the heptem, and it looks exactly the same as normal. Similarly, if we've given a factor V inhibitor or lots of protamine, you might see a prolongation of both of those factors. And so both clotting times are prolonged in this, and we would either wait or we would be thinking about whether this patient has an intrinsic factor problem. In terms of the next step, going down, we're looking at the fibrinogen level. It's the same now as the obstetric algorithm or the trauma algorithm. We're looking for clot strength and fibrinogen. We are giving fibrinogen if it's indicated according to the algorithm, and I've showed you this slide already, and this is the schedule that we use, whether it's apheresis or whole blood cryo, or if we're lucky enough to be able to use fibrinogen concentrate. It needs to be given early because it's the first to fall. The platelet step is next. The XTEM, as you know, reflects both fibrinogen and platelets, and so you need to correct the fibrinogen before you can even look at the XTEM. Make sense? We need to get the functional fibrinogen right, or the FibTEM right, before we go looking, is platelets a problem? And these are the numbers for the cutoff values for platelets to be required. And then there's a more detailed schedule with how many units of platelets to give. And in the middle is a little schedule we've devised to look at the multiplate, which is a lab test we can send up. Often we do it preoperatively. It does take about half an hour to come back, but it could save you giving platelets or point you in either direction. Or you could use some platelet mapping, which is a point of care test that comes with the TEG, a separate TEG cartridge. So DDAVP also helps if the patient's uremic or has renal dysfunction. We would normally give DDAVP as well as part of this step, and it's written on the more detailed algorithm. So thinking about clot firmness management, that's normal. An XTEM at the top, a FibTEM at the bottom. This shows low fibrin contribution, exactly the same as with the obstetric cases I showed you. And so it's a thinner FibTEM and also a thinner XTEM, because the extrinsic one at the top left is both platelets and fibrinogen, so of course it's affected. And if there's low platelets, then you would expect that the fibrinogen, the FibTEM bottom right, would be normal, but the XTEM would be reduced. So I'm hoping that that makes abundant sense to you now that I've repeated it a few times. It's a really important point. Then we get to clotting factors. Prolonged clotting time is commonly improved just by correcting the higher steps in the algorithm. So please don't go giving this early. It may not be indicated. But if you have a prolonged XTEM clotting time after you've done all of those other things, you may have a coagulation factor problem and FFP may be indicated. You need to be careful using complexes such as Berryplex. We do use them for the patient's volume overloaded, but just remember that the TEG test, all the TEG tests look at the intrinsic pathway because of the presence of kaolin, and so it doesn't isolate the extrinsic pathway. It's good to determine if there's coagulopathy or not, but it doesn't really point you into whether or not Berryplex or the 2, 7, 9 and 10 factors need to be replaced, because the intrinsic pathway is activated with kaolin in most of those tests. So in general principles, coagulation factors are assessed last because they are in the greatest reserve. FFP dilutes clotting factors. It's very rarely indicated. And this is a Cochrane review from a long time ago. Essentially, the message is that if the clotting time remains prolonged once you fix the fibrinogen, then consider this. Don't go giving FFP early. It may even increase the risk of other complications. Fibrinolysis, always look at that again, over and over as you go through time. After 30 minutes, you'll be getting a lysis index and you may need more tranexamic acid. So always think about that. In the cardiac algorithm, though, it's rare because we're already giving it. And this is our fibrinolysis image. And so we're looking at normal, we're looking at fibrinolysis, tapering away. And just pointing out that the lysis in the Rotem is logged at 60 minutes after the clot begins, and the lysis in the TEG, it's logged as 30 minutes after the clot is maximal. So even though it's a 60 and a 30, they're actually both looking at similar points in time when it's tapering. It's just a matter of when they started measuring, if that makes sense. Just another example about how using point of care testing in these patients for cardiac surgery can reduce acute kidney injury, thromboembolic events, and it's a good thing to do. But the best science in the world means nothing if you can't get the humans to engage. And I remember one of the obstetric anaesthetists from the UK saying to me that transfusing without a Rotem was like running a case with a blindfold. Someone that came from the UK, where this is really very widely used. So you involve all teams, get the JMOs, the surgeons, the perfusionists, the nurses, everyone involved. It's the key to success. Always use a label so there's good communication and handover. Always use the traffic lights so that you know when to transfuse and when not to. And we've also developed this decision support tool that helps the residents on the ward preoperatively to look at who's at risk for bleeding, looking at fibrinogen and their pre-op multiplate, a bit about rewarming post-bypass and the ICU. So this is also available from me, and just an example of how we have now created another decision support tool. So just to finish up with a few examples from cardiac and vascular surgery. So this is where I spend a significant amount of my life. This is what I look at as a cardiac anaesthetist. And this is our algorithm that I've just gone through. So case number 1, cardiac bleeder number 1. Here are the 4 results. Can we please now pause and fill in a label? FibTem, XTem, INTem, HepTem. Hopefully you can see the abnormality here. There are some things that are very red. Comparing it to our algorithm. Giving you a moment. The learning point here is that the INTem and the HepTem differ by more than 25%. So therefore protamine is required. This patient got 50 milligrams of protamine and 8 units of apheresis cryo based on that low FibTem A5, and the next Rotem was normal. There were no platelets or FFP required. Now the next test I'm going to show you is a TEG result. And this is an elective bypass case. It's given heparin to establish an ACT for bypass. Some protamine's been given, but the surgeon's complaining they cannot see any clot. So we're looking now at the key numbers on the TEG. How strong is the clot? Well, we've got a functional fibrinogen at 19.8 and a CRT at 52. So let's compare that to our algorithm. We're looking at a CFF here that is almost 20, well above the 15 that's prescribed at the fibrinogen step. They will have already received, of course, their dose of tranexamic acid. The first step, though, which I just overlooked, is to look at the heparin difference. So looking at the CKR over the CKHR, it is 3 times or more than double. So clearly some protamine is required and some fibrinogen is required in order to correct this. And once all of that happens, well, already the CRT is more than 44. So platelets are not going to be required. This one is a vascular case. You're called to help someone that's activated the protocol and given some red cells and a little bit of FFP and platelets. You run this test for them because you know how to read it and perhaps they don't. And these are the results. So using the cardiac and vascular algorithm, maybe pause for a moment and we can look at this result comparing the R times to see if we have a problem where we need to give more protamine, and then looking at the functional fibrinogen second. So here's our algorithm, looking at the R time, 16.5 divided by 10, it is increased. Looking at the functional fibrinogen, it is low. And this is a multifactorial situation. You're going to have a heparin, be reversing or treating the heparin effect with protamine, and you're going to be managing the fibrinogen deficiency. Once you've done all that, there may well be a platelet problem. We're at 42 here, we want to be 44, or fixing these top steps may correct the bottom part of the algorithm. We commonly see that. But keeping all things open in your mind, treating with protamine and fibrinogen first, and then checking what else is needed. So that's the end of my examples. And so what are our challenges? What's holding it up, really, is my question. Here's a paper from Anesthesia Analgesia. Axel Hoffman is a West Australian, has done a lot of work in West Australia on this, and he, in fact, works with the World Health Organization. Patient blood management, which of course is a much bigger picture than just viscoelastic testing. It's got to do with optimizing patients' blood preoperatively, intraoperatively, and postoperatively. But all of this patient blood management, of which this is part, what's holding it up? So one study, that came out this year in Anaesthesia and Analgesia was interviewing a whole lot of anaesthesiology trainees and looking at their lack of knowledge on this. And that's where this exact tutorial comes in. So education is important. This is in the US, that particular one, but I think that translates well to here. And an example of this is a paper that we presented, this poster in Darwin, that Dr. Hedge presented very recently in September 2024. And we surveyed locally 100 people looking at barriers to implementation on our campus, barriers to engagement, and what preference people had for education, which included a full video explaining it all, such as this, which included a face-to-face sim, and we are running some of them, and also an online course with CPD, which we are planning to develop through the College of Anaesthetists. So finally, patient blood management. This is a slide from the World Congress of Anaesthesiologists in Singapore earlier this year. It's squarely on the table. It's the challenge for the next cohort of people coming through. It improves patient outcomes, and what the hell is holding it up?